great weekend so far, though I hope the person who got COVID is recovering. Um, as a quick introduction, I'm Longsha. I'm one of the co-founders and co-managing directors of Stanford Healthcare Design Challenge. I'm joined today by Aditya, who is my fellow co-founder. We're really excited to welcome you all to the Stanford Healthcare Design Challenge inaugural kickoff. So this is the first healthcare design challenge of its kind at Stanford, and we're really hoping to use this to pioneer a new model for academic competition. So thank you all so much for being here. And everything will be recorded and posted on our website. We also have an active Q&A session, I believe. So feel free to message us at any time on the Zoom, and then someone from our team will also get back. Quick run of show. We'll do a few minutes of just a welcome remarks, followed by introduction to our partners, then the programming, our prompt, followed by the application, resources, judging overview, and then followed by a Q&A. At the end of the Q&A session, we will also be posting live on our website the prompt and application form. But you as attending this kickoff session will have early access by roughly an hour. So yeah, to get started, let's first quickly discuss the old models of traditional hackathons and case competitions. And we want to preface by saying that we think hackathons are great. In fact, my own startup started after we won a hackathon in New York City a few years ago. And it was a lot of fun, and I owe it to the hackathon for helping generate the idea that has helped me so much in my entrepreneurship journey. But there's so many things afterwards that I really wish the hackathon provided in my 0 to 1 journey. For one, it's how to actually make meaningful change in this very complicated ecosystem that is the healthcare landscape, right? Where there's so many different stakeholders involved, each with their own agendas and priorities.
Yeah, so as Longshan mentioned, right, hackathons, they're a great time. We love a good hackathon. We love the energy that comes from just having a pretty fantastic day or weekend or week when you have the opportunity to really just gather around with a bunch of your homies and come up with something that you think might actually be able to be translated into impact. But let's look at the statistics for a second, right? Only 7% of projects that come out of a hackathon had any activity 6 months after the hackathon ended. And what that tells us is that once you overcome that activation energy, to use our lovely chemistry terminology, it's hard to keep things going. And a lot of ideas from these competitions fail to progress due to any number of reasons. There's a lack of knowledge sharing, there's a lack of exposure to the industry, there's a lack of access to folks who can understand this very dynamic ecosystem within healthcare, wherein there are, I would argue, perhaps more stakeholders than almost any other industry. And if we are trying to figure out how we can translate some of those ideas into impact, it requires having the right people at the table coaching you and the right resources that you can turn to during that phase after the competition ends. And so that disconnect ultimately means that potentially impactful solutions for patients, who are ultimately the ones who will benefit from this idea that you've been able to create, remain underdeveloped, and we're not able to address some of the challenges that these hackathons were designed to solve. So we wanted to do things a little bit differently. Angsha?
Yeah, thanks, Aditya. So for us, we're creating an initiative that is designed intentionally to help move the needle in healthcare. And the way we're doing so is in twofold. The first one is we're really trying to bridge that ideation to implementation gap that Aditya was mentioning. And we do this in 3 different modalities. The first one is we're democratizing all the knowledge about how to really innovate inside healthcare through our open learning series. So you'll hear from people like the Chief Data and Science Officer of Microsoft. You'll hear from an A16Z partner about what truly matters. You'll hear also from the former CEO of Kaiser and the New York Health Commissioner about what truly drives the needle in healthcare innovation from a payer lens, from a government end, from a health system lens. And moreover, we're expanding access through a very vast mentor pool for our selected contestants. These include 50 to 60 senior member levels across the same sort of stakeholders who will be guiding you personally through your journey in 2 weeks in October. And then lastly is engaging the industry decision makers at the very top who will be part of our judging panel. And you'll hear about our judging panel really soon, but these include folks like the director of the FDA for digital health. The second modality that we're really targeting is critical follow-up support to ensure there's continuity in your project idea. So winning teams will receive from us additional stipends for customer discovery and go-to-market. They'll receive advisory board composed of C-suite and senior executive level mentors. They will receive access to additional perks through our partnership programs that we'll also be sharing very soon. And then the key emphasis, though, is that we are here to offer you support to make your ideas a reality. And this isn't it for our vision. Our vision is to go global by this time next year. So after you finish this competition this year, reach out back to us because we're going to be recruiting for our global expansion in the year after. Moreover, if you're a leader within your local organization or your university organization, please reach out. We're really looking to partner with as many as we can to increase our impact. And I'd love to take a moment here to really acknowledge my team, that without who this wouldn't be possible. You'll have the chance to hear from many of them throughout today, but I'll also then jump to our partners to really give a big shout out for all their incredible support. There's way too many of them to list here individually, but we really couldn't have executed this vision without them either. And we hope that you'll also get to know them too through our October and September programming. Without further ado, I'll pass it on to our colleague Richa, who's been sending you all these fantastic emails to share programming and prompt.
Hey everyone, my name is Richa. I've interacted with a few of you via email, and I'm super excited to meet the rest of you. As you may already know, if you've been tracking our LinkedIn and Slack, we have an awesome September planned for you. We have a bunch of events with great speakers and panels to help you get a better sense of the problem area and to connect you with professionals in the field. So today's the big day, September 1st, where we're launching the application and the prompt and have a Q&A session soon with Dr. Tony Dodek from United Healthcare. Week 2 is focused on getting a better understanding of the healthcare ecosystem. Week 3 is focused on Healthcare Policy 101 and a policy panel. And week 4 is focused on operationalizing ideas and go-to-market strategies. And then applications are due at the end of the month on September 30th. We highly recommend you take advantage of our awesome mentors and advisors that we have lined up. And remember to register for the Zoom links that are posted in our emails, LinkedIn, and Slack. All these sessions will also be recorded and posted on our website if you can't make any of them. So now flipping to October, we're focusing on our events on preparing our teams for pitch day. On October 4th, we'll send out team acceptances to 12 teams of 3 to 5 people. Week 1 of the competition is focused on the buyer perspective and ideating with our mentors. And in week 2, we're focusing our programming on how to pitch and storytell. And lastly, our final pitch day is on October 18th. So please let us know if you have any questions about programming or our events. And now to share a prompt, I'll hand it over to Shri.
Great. Now for the really exciting part where we have our prompt here to share with you, and we worked really hard with our mentors and advisors to refine our exact problem area and making it relevant for healthcare systems and policymakers alike. And don't really worry about screenshotting or taking notes about this right now. We'll upload the full prompt online to our website, and it'll be written out in our application form as well. So here it is. The prompt is to design a financially sustainable and scalable solution that is tailored for vulnerable populations that effectively addresses their social determinants of health needs to enhance engagement with healthcare and improve health outcomes. So consider focusing on a specific population and their needs. For instance, this could be individuals with housing insecurity, substance use disorders, or disabilities. Your solution should then demonstrate value to stakeholders like payers, patients, or health systems, and outline the necessary steps and feasibility for implementation to achieve long-term, impactful improvements in the lives of these populations. Innovation should aim to strengthen the 3 pillars of healthcare, including affordability, access, and quality. Examples here may include preventative care, wellness, or trust building. So with our QR code here, we have additional information about thought questions and definitions. So definitely take a look at our QR code and our document attached. And we also have an excellent lineup of expert speakers in the coming months here. So yes, so please attend our speaker events to get a deeper dive into the problem area as well. Now I'm going to pass it off to Aditya to talk about the application.
Yeah, thanks so much, Shri. So everyone's favorite part of everything in their entire life is applying for things, right? So I'm just here to kind of give you guys a little bit of context about the application itself. And so this is essentially what you all are going to be submitting at the end of September, after you've had the opportunity to kind of do a little bit of research, do some customer discovery, go to some of these sessions and understand really what type of issue and what the scope of the issue you're trying to solve is. So at the end of September, we'll be picking from all the teams that submit applications, the finalists who will then move on and move to the final pitch portion in October. To just give you a little bit of a framing about how we're approaching this, there'll be not too many questions, a couple of longer sort of paragraph format questions, somewhere are in the range of 300 words. And we'll be thinking about this and weighting these responses based on kind of 3 general criteria. Who are you and what your motivation is, how you're thinking about solving this problem, and then the idea itself and its feasibility. Although as we move forward into the October phase, that final portion of the idea itself and its feasibility will take center stage. And that will be the core judging criteria for many of our judges. But of course, we can talk about more in a month or so. So just to kind of break that down, first, we're going to be talking about who the team is. We want to know who you are, where you're coming to us from, and of course, we're going to be blinding our applications, but we'd like to see a little bit about what the team composition is, and we want to ensure that there is adequate kind of understanding represented for the problems that you all are trying to tackle. Then we want to know a little bit about what you've learned over the course of the last month. What types of sessions have you attended? What Q&As have you engaged with? Who have you spoken to about this issue? Is it patients? Is it policymakers? Is it physicians, right? And then we want to know your why. What's your motivation? Where are you coming at this from? Why are you and your team uniquely positioned to be tackling the problem that you want to address within the scope of this prompt? And finally, a little bit of spoilers, right? We want to see essentially what kinds of ideas you're thinking about. Are you going to be tackling some of these issues in the unhoused population? Are you going to be looking at access to care? Are you thinking about the financing or data security side of things? Who knows, right? We want to just see at a high level, without seeing your final ideas, what directions you're trying to take things. And so let's see in that application what your thinking is to this point. So we're happy to address further questions about the application itself moving forward. But for now, feel free to kind of log that QR code, which will be available on our website as well, which will link you to the application. And from there, we'll have the opportunity to move on to sort of the next phase. So I'll pass it on.
Yes, so a huge resource that's going to help you get started is the Slack workspace. Here is the link. You can just scan this on your phone and it will take you to the workspace. And you can use this workspace to basically connect with other people, the mentors and the SHDC team. And you can use it to get updates through the various channels. You can use it to form teams and also work together on projects. The 4 channels that I would worry about are general, where it's the general channel. You'll have announcements and updates on that channel. The team formation and project ideas, where you can introduce yourself, be bold, and find teammates to share and discuss project ideas. The Q&A, where you can ask questions, and a channel for events that will prepare you for upcoming events and registrations for that event. And now I'd like to pass on to my colleague Sherry to talk about the website.
Hi, everyone. My name is Sherry. Nice to see everyone here. We've also created a dedicated website for our design challenge, and we will update speaker and event information as we go. Specifically, you will find welcome message, our model and solution to address idea, to implementation gap, as well as our prompt and applications. You can scan the QR code also provided in the slide to check out the website. We'll also upload YouTube videos from our speakers and workshops as we go. Although we highly encourage you to attend live all sessions as much as possible, which helps to address any questions that come up. Now I'll pass it on to Langsha.
Actually, I'll get this one. Hey everyone, my name is Akash, and I'm excited to go over our judging process and what that will look like. So to start off and just clarify, the judging is how we will evaluate the 12 selected teams and finally determine who the winners of the competition are. So to start off, we've assembled a really rock star crew of judges. There's honestly too many accomplishments to list one by one, but here are the people that will be on our judging panel, really true leaders in healthcare with decades of experience each. And I think the awesome thing is they're all coming from different angles of tackling SDOH. So we have people from health systems, insurance companies, even like some academia as well, so and government. So really a lot of awesome and experienced perspectives that we'll be evaluating. And there's really 5 main axes that these judges will be thinking through when evaluating the top 12 teams. The first kind of criterion is the understanding of the problem. So they're gonna look at the application and see, like the submission, and see how clear is the problem as stated. Is it evident that the team not only understands like the specific problem, but also the context in which the problem exists? The second matter is the solution value. And what this really means is you could sort of boil it down to what is the kind of population of patients that would be impacted positively with the solution, and for that population of patients, how significant is the potential impact? The third criteria is the feasibility of implementation. At SHDC, we're really all about translating ideas into real healthcare impact. So the judges are going to want to look for how realistically could this team implement this idea, and also how realistic is it that this idea will have the overall intended impact. The fourth axis is the overall presentation. So of course they're going to want to see a pretty high quality presentation. Specifically, does it do a good job of portraying the actual problem that the team is working on, and is it relatively straightforward to understand the solution and the idea that the team's putting forth? And the fifth criteria is called product differentiation. You can think of this as a little bit of like a wow factor, but basically the judges are going to ask, what's unique about this idea? Is it something new, or is it more of a commonplace opinion? And them as experts, I think, will have a good say on how unique the idea is and how differentiated it is. So next, we'd love to talk about the prizes that we will be offering the winning team. So our awesome team of judges will look at the 12 submissions from the selected teams. And the first place team will be awarded a $2,000 grand prize. And the winning team will also receive $1,000. This comes in the form of follow-on support. And in the mission of really translating ideas into real healthcare impact, that $1,000 should go towards really any expenses that are needed to help the team continue on and realize that vision. Additionally, the runner-up team will receive a $1,500 cash prize. We're also offering a lot of other types of support to the winning team. So we have a whole category that we call kind of like fast track. Some of these are still in the works, but the first thing is a potential entry into the American Heart Association's EntreSlam competition. This is sort of like their accelerator. We're also offering tickets to A Healthier We's inaugural 2025 Healthy America Summit. This is an awesome event with like a brand new sort of event. Next, we have a potential admission into the InterSystems International Business Accelerator. And finally, a potential mentoring session with United Healthcare's Massachusetts arm C-suite team. And finally, there's a few different other types of support that we're providing from a few different partners that we have. Starting off with Stanford Healthcare Innovation Lab, who's offering continued mentorship. CloudForce is offering AI credits with Microsoft Azure. The Emergency Medicine Innovation Collaborative is offering continued education and mentoring. VZ Consulting, which specializes in AI, data, and SDOH consulting, will offer continued mentorship. Archive is offering services for financial storytelling. And finally, we're also just offering general support and the continued relationship with really like mentors that we've assembled. And I should say that this category of general support is a lot of it's depending on sort of the fit between the team's idea and the proposed solution and kind of the partners that we can pull in for that given idea, as long as there's a good fit. So that's kind of the prizes that we have in store. I'll pass it back out to Longsha to introduce our awesome speaker.
Yeah, thanks, Akash. I'm delighted to introduce Dr. Tony Dodek. Dr. Dodek is a distinguished leader in health system innovation, known for his work in enhancing clinical quality, patient experience, and affordability. With deep expertise in value-based payment designs, Dr. Dodek has successfully collaborated with payers and providers to drive meaningful improvements in healthcare. His areas of expertise extend to clinical quality improvement, pharmacy management, and cost trend mitigation. Currently, Dr. Dodek serves as the medical director of United Healthcare's One Care program. His past roles include Chief Medical Officer at Allway Health Partners and Associate Chief Medical Officer at Blue Cross Blue Shield of Massachusetts. Dr. Dodek has led the successful implementation of telemedicine programs, chronic disease medication management using algorithm-based approaches, and the development of virtual care networks. He is also skilled in evaluating new-to-market products and drugs, assessing their value relative to existing options to determine market viability and coverage. Please join me in welcoming Dr. Dodek to our virtual stage.
Thank you, Longsha. It's a pleasure to be here. Good afternoon, everyone. I'm Tony Dodek. I was a practicing pediatrician for over 20 years, and I've worked in managed care for about the same amount of time. And as I look at my image on the screen, it occurs to me that it may appear that I'm in a sauna. I am not. I am sitting in a screened-in porch in the White Mountains. So I appreciate everybody taking time out of the long weekend to attend. We'll go to the next slide, please. So I'm just going to spend a few minutes giving a brief overview of social determinants of health from a managed care perspective, more specifically from my personal experience. And this slide shows a list of populations that are more likely to be affected by these determinants. And those are patients with chronic disabilities, chronic disease, substance use disorder, and behavioral health conditions. And it's important to consider that many of these diseases did not occur alone. Many patients will have a combination, particularly those with disabilities, chronic disease. There's a relatively high prevalence of both substance use disorder and behavioral health conditions. And when you think about disabilities, there are two big buckets there. There are patients that have intellectual and developmental disabilities, and those with physical disabilities. The types of chronic diseases that are most prevalent are conditions like chronic obstructive pulmonary disease, chronic heart failure, chronic kidney disease, diabetes, and depression and anxiety. And people with disabilities, their major challenges are around getting durable medical equipment and equipment to help them with adaptive equipment that they can use for their activities of daily living. Those that have chronic disease tend to have some degree of social isolation. Their coordination of care is usually lacking, and they have trouble keeping track of their medications and taking them consistently. Next slide, please. So in this slide, I just wanted to give a little bit of the payer context for populations that are at risk for social determinants. So if you look at the top three lines here in terms of Medicare, Medicaid, and the ACA, if you add up those populations, that's about 2/3 of Americans. And you will hear politicians, particularly in an election year, talk about the merits of so-called Medicare for all. That, that some people feel that having everybody covered by a public payer, single payer, may have some advantages. And I'm not going to go into the politics of it, but I think it's important to realize that we're 2/3 of the way there, that most people in the US are covered by some type of public supported payer. The second point I want to make is those with commercial insurance, and those are probably most of the people who are on this webinar tonight, are covered by employer-sponsored plans. So your employer will kick in a certain amount of money, and then you'll pay a premium, and that's the way most workers in US have their health insurance covered. Of those people who are on commercial insurance, about half of them have high deductible plans. And that means that the first dollar that you incur in any given year, you have to pay out of pocket. So basically your insurance doesn't kick in for an individual until you've paid about $1,500, and for a family about $3,000. And the reason I'm making this distinction is because people with commercial insurance who have high deductible plans behave like those who don't have insurance, or those who are on Medicaid or Medicare. So the populations that are highlighted in red here are those that are very, I'll use the word price sensitive. And it's not just the people who are covered under public plans, but it's also about half those people who are covered under commercial insurance. Next slide, please. Now, as Langsha mentioned, I'm currently the medical director for a United Healthcare product in Massachusetts. It's called OneCare. And OneCare is an example of a Medicare, Medicaid plan. So it's a combined program funded by the federal government and the state Medicaid program. And in order to qualify for this product, members have to be poor enough to qualify for Medicaid, and they have to have chronic illness that qualifies them for Medicare before they turn 65. It's a very specialized program. It comes with a variety of benefits, and some of those are the ones that I list here. So I wanted to use this as an example to illustrate what some of the public plans have available to help people with social determinants. So there's a whole list here of long-term services and supports, and members can qualify for a certain number of hours a week, depending on what their disabilities are, what their needs are. But it can be anything from having a day program where they go to 5 days a week, to having meals delivered, up to 3 meals a day, having a homemaker come in and do some housekeeping, a personal care attendant that will help with things like bathing, dressing, and mobility, and private duty nursing if they have some clinical needs. So as you're working on your solutions, just keep in mind that there are these services that are in place, but these don't really address the social determinants, right? These are services that help support people. So you really want to be looking for things that underline those social determinants. Next slide, please. So other examples that I'd like to share. The first is intensive case management. Now, case management is something that all health plans do, both public and private. And it really kind of evolved because physicians don't really do case management, or hospital systems historically didn't do it, or didn't do it well. And for these populations that are at risk, health plans have developed intensive case management, which comprises a whole team of clinicians. So it's a holistic approach. There's a nurse case manager who's usually on point, who's kind of the quarterback and coordinates all the care, a medical director, pharmacist, nutritionist, a BH clinician. And in addition, there are staff who have expertise in housing, employment, and there are community health workers who actually go out into the community and work with members. One of the other things that we've implemented here in Massachusetts, and many other plans have done the same thing, are peer recovery coaches for members who have substance use disorder. Peer recovery coaches are people who are in recovery. They have real life experience, and they're very effective in helping people navigate their sobriety once they're out in the community. Additionally, there's a benefit that is unique to OneCare, which really is one of the reasons I decided to take this position. The flexible benefit is a pot of money that's available for coverage for items or services that are not part of the medical benefit. So as an example, during the summertime, I've had some members who have very bad respiratory disease. It's 90 degrees out and it's very humid. buying air conditioners for these type of people, mitigate the need to go to the emergency room. And so an air conditioner wouldn't be covered by traditional health plans, but having this flexible benefit of being able to fund air conditioners, microwaves for people who are getting home delivered meals. It doesn't make sense to deliver meals if they can't heat them up. But again, those things aren't traditionally covered in most health plans. And then there are also vendors that can be very helpful in addressing social determinants. So we recently developed a partnership with an organization called Farmbox RX, and they're working nationally. And this is an organization that packs up fresh produce and also fresh meat for certain members and pantry products. And depending on the need, they will send out these boxes monthly, quarterly, as much as the health plan wants to support it. And we found that using this for our diabetic patients has increased their compliance, their engagement, and they're more likely to get their blood checked to make sure their diabetes is under control. They're more likely to get annual exams for their feet and their eyes. So it's been very effective. And I use this as an example because you need to think about how you're going to engage members or patients. There's been a lot of good ideas, but if people don't use them, if they don't resonate with the patient/members, they're not going to be that effective. And another example, and this is, I think, very innovative, and I don't have any experience yet, but we'll be launching this in the next couple of weeks, is an organization called Art Pharmacy. And it's exactly how it sounds. This organization has curated a suite of cultural experiences for members. So it could be going to the opera, it could be movies, it could be going to museums, taking lessons in art or music. And the intent here is to get people connected and to try to limit their social isolation. And they have data from previous experience in other markets that is very promising, and I'm hoping to replicate that here in Massachusetts. Next slide, please. So I'm going to end just with a few tips, with the caveat that these reflect my biases. So SDOH are symptoms, right? The cause that results in people being prone to SDOH are really poverty and lack of education, and that causes a loop. So if you're born into poverty, your educational opportunities are usually not as good as they otherwise would be for more affluent people, and that circle replicates over the course of the generations. And unfortunately, people of color are more prone to being included in this category. I also want to leave you with the thought that these problems are extremely difficult to address. If it was easy, they would have been solved already. And I think, for your purposes, try to identify a solution that may be cross-dimensional in terms of the factors, different disciplines that may work together for a solution. And also from a healthcare perspective, most medical directors at health plans will say, okay, sounds like a good idea, but what's the return on investment? So whatever you develop is going to cost money to implement and to run. Health plans are going to be much more open-minded if you can make a case that says, yeah, it's going to cost $1,000 per member per year, but you're going to save $10,000 in medical claims because this is effective in some specific way. The third point is that this is a population that's very difficult to engage. They're either kind of checked out, they just don't want anybody else in their life. They're kind of cynical after a certain amount of time, excuse me, because their experience with the healthcare system just hasn't been beneficial to them. And so finding people where they are, going to food banks, going to homeless shelters, methadone clinics, and offering something that engages them, something that they're really going to get excited about, something that they feel that they need, is going to be more successful than the greatest idea that just is not attractive to your target population. And then finally, I've seen a lot of proposals come across my desk over the last few years on artificial intelligence, machine learning, different bots and apps and remote therapeutic monitoring. And they work to some degree for some people, but I really feel that they do not work well in isolation. And I think the most important thing is to have a caring human associated with whatever the intervention is for it to be successful. And that's not always easy to do. And that there may be solutions that are effective without that. But I think to be maximally successful, that would be the approach I would recommend. I think that's my last slide.
Yeah, I mean, that was amazing. Thank you so much, Tony, for sharing your thoughts. And yeah, just really want to echo to the audience that the key aspects of what Tony's mentioning, right? That poverty and lack of education are very critical aspects about the challenges that these populations often deal with. And that really, when it comes to innovation, it really matters to meet whoever we're helping at where they are. And Tony shared a lot of different examples, a lot of great ideas that we really encourage you to take to heart. And I'm just going to take a few minutes to ask Tony a few questions. And I would invite all of y'all to use the Q&A section to submit your own questions. And we'll be able to spotlight you in the last 10 minutes of our session today so that you could even ask Tony directly. But Tony, I want to just kind of get started with one of the key questions that we often hear about, which is this phrase of misaligned incentive. Right? People use it all the time. When I was having a class for the digital future of healthcare, we asked every single speaker, that single question of, what do you think is one key thing that you want to change in healthcare? And without fail, almost every single person said misaligned incentive. So I want to hear from you though, from your perspective, what does this really mean? What strategies, whether it's through structural change or innovative approaches, can actually be used to realign these misaligned incentives, so to speak, to improve health outcomes?
Yeah, it's a very good question, and it's one that's vexed the healthcare system really since Medicare was implemented back in the 1960s. So my definition of misaligned incentives is that the reimbursement for healthcare in the current system, both for public and private payers, is based on a fee-for-service chassis. So that the more that a provider does, the more they can bill for, the more money they're going to make. But that does not incentivize good outcomes or quality care. And we've been trying, when I say we, I mean health plans broadly, have been trying to address this in different ways. And in Massachusetts, when I was working for Blue Cross Blue Shield, we started something that was called the Alternative Quality Contract. And for those of you who are interested, you can Google that. There's a lot of literature on it. But it's basically a capitation model where a provider gets a budget for each member that they care for. And depending on how sick that population is, that determines to some degree what the reimbursement is. But what the AQC did that was different from standard capitation is that providers got bonuses depending on outcomes. So certain quality measures, If they spent less money than was budgeted, then they got to keep some of that. However, if they had poor quality and they save money, they wouldn't get the extra money. So incentives in that model were more aligned to drive providers to really efficient care that had good outcomes. And it was moderately successful. I think it's a step in the right direction, but it hasn't changed the whole problem. And there's reasons for that, which get a little too technical, and I think I could leave for another time.
Yeah, it makes a lot of sense. And how would you say are the key challenges that payers face, especially when it comes to healthcare innovation? Right, you were giving some great examples like art pharmacy, but how long, let's say, did that even take to negotiate such that you're working with this organization? What were the key weigh-ins or factors that mattered the most to a payer standpoint to establish that buy-in?
Mm-hmm. So it goes back to what I think I mentioned before about finding an aspect of the condition that's important to the member and therefore to the health plan. So something like art pharmacy, our care managers almost to a person talk about how isolated and lonely many of the One Care members are. And so that was a topic that we actively tried to seek solutions for. And art pharmacy was an example of something that really just resonated with us very well. The second thing that is really more of a warning than anything else is that the IT systems within health plans are stretched to the limit on a daily basis. So just keeping the lights on, collecting the data, processing the claims, any ask of a health plan that requires IT commitment or IT resources makes it very difficult to get over that implementation threshold because it costs a lot of money and the resources just aren't really there. So those are some of the challenges.
Makes sense. And last question, just for time's sake, but do you have any do you have any advice just for the teams competing in this year's challenge as they develop solutions in this space?
Yeah, as I was saying before, it's a big problem. The cliche I would use is don't try to boil the ocean, right? Try to pick a lane, find something that is targeted towards a certain subpopulation, and something that you think is actionable. And again, it needs to be in the end something that makes financial sense for a health plan to want to participate. So if it's wildly expensive, or if it doesn't have determined endpoints that improve quality or outcomes, it's less likely to be adopted.
Yeah, this was super helpful. Thank you so much, Tony. Just want to give a time, for anyone else who's participating that if you want to ask a question to Tony, please feel free to go ahead. You can either post in the hosted panelists or you can put in Q&A. Otherwise, we can also take the time to respond to a few Q&As live that we were seeing throughout the session. So there's one question that anonymous attendee asked, which is on return on investment, are you ideally looking for a problem or solution that's especially venture backable or a small business level okay? For us, what really matters is social impact, right? As long as you're able to deliver social change to a population at need, that's all we care about. Whether it's VC backable or not isn't a key priority for us. And yeah, it seems like we have a different question directed for Tony, which is what has been a proposal re-SDOH that you've received that you were impressed by and what happened afterwards?
So I'm sorry, Langsha, can you repeat that again?
Yeah. What was the proposal regarding social determinants of health that you received from your, either of your positions that you were impressed by, and what happened afterwards?
So the one that is has been most successful is the one I've already shared, and that's the FarmBox RX. And the reason that was wildly successful is, and I don't think I mentioned this specifically, but the population that we're talking about is very hard to engage. The reach rate, to do care management is about 20%. So 80% of people just don't answer the phone. But the FarmBox RX, when we started to send out those boxes, we had people that we had been unable to reach who had talked to their friends and were calling the health plan saying, I hear you're sending out food. I would really like to participate. And we increased our reach rate by 50% just by doing this really very simple intervention. And the food is not that expensive. The ultimate ROI is still to be determined, but just the fact that we can now engage people who we couldn't manage at all, I'd be surprised if this isn't going to be wildly successful.
Thanks, Tony. And we have a participant that asked a phenomenal question that we'd love to spotlight, and she can ask directly.
Hi, Tony. Thank you so much for your presentation. My name is Betty Volante. I myself have been working a lot with social determinants of health as well. And throughout my experiences within this past year, my question to you is, because now a lot of health centers are thinking of adapting to value-based care models, what are your thoughts of this change in terms of the healthcare system, and maybe will this lead to more of like an interoperability outcome for patients, and have this exchange, especially including maybe lead organizations who work with community health workers? I would love to hear your thoughts of like physicians and community organizations to make that more of an interoperability because of value-based care.
Mm-hmm. Yeah, thanks for that question, Betty. It does have a lot of potential to do that. So I would encourage you to Google that AQC that I mentioned earlier, because that is a value-based care initiative, and it was really the first one in the country. It was started back in, I think, 2011 or 2012. And by designing a budget that is not based on fee for service, so that providers don't have to like churn to see a lot of members to make revenue, they can then start to take that revenue and invest it into other ways of caring for the population. So it's designed so that there are resources to kind of fill in the cracks between visits, either a care management solution or community health workers. Practices could hire these resources on their own, depending on what their identified needs are for their population. So I think a value-based care approach is on the road to fixing some of the ills of our current situation. I will share that in Massachusetts, the AQC was successful for the first couple of years, but most of those savings were attributable to changes in sites of service. So what the provider organizations did is, instead of somebody getting admitted for a procedure, it might be done as an outpatient. Instead of a hospital clinic, it may be done in a surgical day clinic. And the types of savings that you would hope to see from investments in other areas to try to address the social determinants didn't help as much as I had hoped. There was some movement of the needle, but I don't think it's the final answer. I hope that answered your question.
Yes, thank you so much for that insight as well. Thank you.
Thanks so much, Shani. So we have a couple more questions that we can answer live, just briefly. So there was a question that came in about key dates that we need to know in October. Very briefly, that can be found on our website, but we're looking at October 6th for a kickoff event and October 18th for the pitch day. But please feel free to stay up to date on the Slack and then check that out on our website. And another question that came in was, could I work on a solution that helps providers who supports vulnerable populations? I think, speaking for everyone, absolutely. Providers are one key sort of factor that comes into play when you're deciding how to create sustainable solutions. And so if you can come up with something that supports them in their ability to care for folks who otherwise might not have access to care or adequate care for whatever reason, then absolutely jump on that. So another question that came in for Tony was, this is by Selen. Since ROI isn't able to be truly predicted, like you said, for FarmBox, how do you go about deciding to fund a project when you don't know all the numbers?
Yeah, that is a challenge. And when I talk to prospective partners, I ask them if they're willing to share the risk, right? So if they're willing to put some of their money where their mouth is, if they have confidence that what they're going to do is at least cost neutral, that gives me and the health plan some reassurance that both from a financial perspective, but almost from a faith perspective, that this may be successful. So it doesn't have to have a firm ROI in the beginning. You know, it could be something that is forecasted. But if you have the funding and you're confident in your proposal, if you say to a prospective payer, I can guarantee you for the first year, you're not going to lose any money. We'll put some of our fees at risk. And beyond that, then you can collect the data to determine exactly what a proposed ROI is. And together with your payer partner, you can tweak the intervention and then measure it going forward.
That makes a lot of sense. Yeah, thank you for addressing that. Another question that came in was really around why you think that mission-motivated startups or other kind of new initiatives have failed in the past, particularly in the social determinants of health space. Since you've shared some examples of great, successes, well, really kind of building on that, I think.
Yeah, there's not one answer. You know, I suggested that you try to focus your population and your intervention, but you don't want it to be too narrow either. You know, so, you know, for example, I talked to an entrepreneur within the last few months who had a great solution for behavioral health issues in the Chinese American female population. And what they had proposed made a lot of sense, but there was no way that I was going to get a health plan, my colleagues within the plan, to spend resources on that narrowly defined population. So as you're thinking about what you want to do, it has to be an issue or a population that is a driver of health plan resources, of payer resources. So that's the number one thing I think that people must don't do. The second thing is what I said previously is the resources around IT. If you're designing something that is going to take a lot of resources from an IT perspective, that's almost dead on arrival. It's just not going to get there. So those are the two things I would say to answer that question.
Amazing. Well, we're wrapping up here, and I want to be respectful of everybody's time. So I first want to thank you so much, Tony, for being willing to share your, I suppose, evening with us over on the East Coast, and really appreciate your support in this competition. And you'll be seeing more of Tony, of course, for all the attendees over the course of the next couple of months. I want to wrap up with just sharing a couple of quick final details. First is the big upcoming deadline, as I chatted about the application previously. That will be due on September 30th. So just keep an eye out for that as you move forward in building your teams, which you can do on the Slack space, and as you consider what types of solutions you want to build. Keep that in mind as sort of the initial application deadline before we move into the more final stage in October. The other thing I want to shout out is our next event, which will be happening this coming Friday on the 6th at 9 a.m. PST, so Western time. That's with John Gorman, who we think that will be able to offer some really amazing insights to all the team members and all the teams who are able to attend. He's the founder and chairman of Nightingale Partners, the first venture fund to invest in early stage social determinants of health ecosystem companies, in which structure tailored interventions with health insurers, local government, and provider organizations. And so from really what you've learned today, you'll see that we have a pretty wide array of stakeholders at the table who will be able to coach you moving forward, and you'll be able to hear from all of their diverse perspectives over the coming month. Now, we want to thank you all for joining us today and sharing your evening with us. And we look forward to seeing you throughout the course of this competition. We are available as a resource, and we look forward to seeing what kind of impact that you can have on patient care.